Hello and good afternoon. You're very welcome to our Clinical Leadership webinar series from the NursEduPal IMPACT team. Today is the fifth in our series of 6 webinars, and we're delighted to be joined by Dennis, who will be talking about the dying phase and saying a final farewell. As you may know, I am a project officer with the EAPC. Patricia White is my name, and I'm joined every week by Guillermo, also from EAPC, who's been really helpful with the technical backup in the background. Just to give everyone a minute or two just to join in, we just have this short introduction, as we have people who are joining from all over the world. This webinar in Teams is accessible in terms of language and size. So you can change the size of the slides, and also sometimes the text on the slides can be translated into different languages. This webinar is being recorded, and it's been used to put together a suite of resources that we have on the NursEduPal IMPACT website, and it will be available in the coming weeks along with all of our webinars. As an attendee, we cannot see you and we cannot hear you, but we really want to engage with you. So we would like you to make use of the chat function throughout the presentation. And just to ensure that you are aware of how to use the chat function, I'll ask you now just to put into the chat where you're joining us from on this, hopefully a sunny Friday afternoon. So it's not so sunny everywhere. Thanks. Good to see that some of you have managed to find the chat function, and it's nice to have this interaction when we're throughout the webinar. At the end of the webinar, I will put up a slide which will give you a QR code bringing you to where you can download your certificate of attendance. And also we have an evaluation form, and it's really important that we get this feedback from you. So we'd really encourage you to take the time to fill out the evaluation form, and then you can download your certificate of attendance. All that's left for me is to say that we're very happy that you've joined us here this afternoon, and that we really hope that you enjoyed the webinar. I'll hand you now over to Danny Varecki, who will be chairing the webinar. Thank you very much.
Hello, good afternoon, everyone, and a warm welcome to all of you joining us for this 5th session in the 2nd series of the NursEduPal IMPACT teaching webinars. As you may know already, in the 2nd series, we focus on themes that are important for those aiming to grow as clinical leaders in palliative care. I am Dani Verreke, and I'm the coordinator of the NursEduPal IMPACT project, and I'm also the research coordinator at the School of Nursing of West University of Applied Sciences in Bruges, that's Belgium, and I share that responsibility with my colleague Veerle Coupé. Once again, I would like to remind you that the content we share in our webinar series is aimed at the generalist healthcare provider, not at a palliative care specialist. As Patricia already mentioned, the recordings of all sessions, along with the presentation slides, will be made available on our project website. I invite you to visit our website already, especially the project research page. For now, you can find there the webinars, the presentations, and most of the course manuals already. And for now, they're only available in English, but we are working very hard to offer most of the materials also in Romanian, Finnish, and Flemish. Besides the webinars, we're also preparing e-learning modules and practical impact tools. And these materials all cover the same themes and content as the webinars. And all of these resources are part of our commitment to support you on your path towards becoming a palliative care influencer. Now I have the pleasure of introducing today's speaker, Dennis de Metz. Dennis is a registered nurse, a psychiatric nurse to be precise, and master in nursing and midwifery. I find that a very difficult word. Last year, he obtained his PhD on the attitudes of Belgian nursing students and their future role and skills towards euthanasia due to unbearable mental suffering. Dennis is a senior lecturer at the University of Applied Sciences at the Erasmus Hogeschool in Brussels, in Belgium. And I met Dennis in 2021 in the same way I met Christine de Bossere, who talked already about advanced care planning a couple of weeks ago. And I tried to unite all palliative care lecturers of the Universities of Applied Sciences in Flanders into a learning network, NursEduPal Flanders. And just like Christine, Dennis joined enthusiastically, and we've tried to collaborate and help each other out ever since. Today, Dennis will talk about the importance of recognizing the onset of the dying process and the importance of final farewell. Dennis, we're very pleased to have you with us today. The floor is yours.
So if things go well, you should now be able to see the PowerPoint.
Yes.
All right. Good afternoon, everyone. So thank you for the nice introduction. And as mentioned before, so today we will have a webinar on the dying process and final farewells. So we will start with an introduction, and then we will have some objectives, and then we go specifically into the dying phase. When does the dying phase start? In the dying phase, you not only care for the patient and for the close ones, but also for yourself and the other caregivers. And then we have a focus on the final farewell. As Donny mentioned, so I'm a nurse by education. I'm a psychiatric nurse with a bachelor degree and a master degree. And so my PhD and my postdoctoral position at the moment is more specifically on euthanasia. I have some working experience in the hospital as a mental health nurse, and the last 13 years as a lecturer and researcher at university and university college. So in this webinar, we address the topic of dying and trying to answer the following questions, and we will try to do it in an interactive way. So what is a dying phase? When does a dying phase start? How do you recognize it? Who is involved? Where does a dying phase take place? Why is recognizing the dying phase so important? And we discuss the final farewell and address the following questions, which are, what is a final farewell? When is it time for a final farewell? And why is saying a final farewell so important? So after this webinar, you will be able to define what the dying phase is, describe what the dying phase, when the dying phase begins, recognize the signs and symptoms that indicate the dying phase, identify who is involved in the dying phase, describe where the dying phase can take place, explain why recognizing the dying phase is important, and explain the what and when of a final farewell, and finally understand the relevance of final farewells and explain this to patients and close ones. So a question for you now, and you can answer in the chat. I have a look at, I have an eye on the chat. What is a dying phase? What do you think? What is the color of the terminal phase? So this is the traditional theme about palliative care and the different phases in palliative care. What would be the color of the terminal phase?
People are a bit shy, nothing yet in the chat.
Do you think it's in the green one, the gray one, the blue one, the black one, or the pink one?
Heidi says blue, dark blue, black, blue, pink, pink. All the colors come up, Dennis.
Right, that's good. So the cure care diagram, which is the one you can see now with all the information on it, gives an overview of how care goals change as a function of care needs and how palliative care needs evolve within an illness trajectory. And then I don't know, are you able to see my cursor or not when I do this?
Yes, yes, we
Okay,
can see it.
so the dying phase is only a small yet inevitable part of palliative care. So it is the dark blue, black part is the dying phase. And during the dying phase, there is a need for terminal care, and all attention now is given to maximum comfort on a physical, psychological, social, and spiritual level. So this is the dying phase. So now we focus really on this final phase, on the terminal phase. And the dying process depends. Does the dying process depends on the illness trajectory? So do you think there will be differences in between the dying phase depending on the pathway you have, like the blue one on oncological, the pink one on chronic organ failure, or the yellow one on frailty? So will there be a difference in between the terminal phases depending on the trajectory you had?
We have a couple of no's coming in. No, the final common pathway is the same regardless of the underlying disease. Stain thinks there is a difference. Always individual, but patterns can be seen.
Okay. So that's good. So we have some yeses, some no's, and some in-betweens. But actually, the course of functional decline during a palliative care pathway is very different for an oncological, chronic organ failure or frailty pathway. But the dying process is the same for all three pathways. There is an initial gradual, but then rapidly increasing deterioration of one or more of the 6 vital organ systems. And so eventually a cascade of events occurs leading to death, which is the final common pathway. So it's not really the how it was the pathway you had before, one of those three. In the end, in the final phase, there will be not that much of a difference. During this webinar, I would also like to tell you the story of George. George is a 60-year-old retired colonel. He has been suffering from kidney failure for over 30 years and receives dialysis treatment for his condition. While on vacation in Spain, George experienced severe diarrhea. When he got up to go to the bathroom, he fell. His daughter and son-in-law were with him and helped him up, as well as assisted him with washing. The next day, his son-in-law took him to his dialysis appointment, but during the dialysis session, George lost consciousness several times and was subsequently admitted to the hospital for observation. George was admitted to the intensive care unit. After extensive examinations, it was found that he had internal bleeding in the esophagus or stomach. Multiple gastroscopies were performed, but the source of the bleeding could not be found. George has 3 children, one of whom is a nurse. And it became quickly clear that the situation was seriously, so the children went urgently to Spain. This is the first start of the story, and during the webinar, the story continues. So, when does a dying phase start? First and foremost, recognition of a dying phase leads to a better quality of life and dying. This is because there is less inappropriate care of overtreatment, including diagnostic, medical, and nursing interventions. Inappropriate care in the dying phase makes a family feel that their close one has had a difficult death. Recognizing, so that's the second one, recognizing and specifying the dying phase is important for the patient and close ones. It brings peace and clarity. There is a time to say final farewells, and this helps the close ones to come to the terms with their grief. And finally, recognition of the dying phase has an important impact on communication between caregivers. There is agreement around the goal of care, namely maximum terminal comfort. As the end of life approaches, changes occur, both physically and psychologically. It is possible that not all the changes described below will occur, as each death is unique. So I saw in the chat previously on that someone mentioning like each death is, or every situation is unique, and that's correct. Each death is unique as well. Determining the onset of the dying phase is mainly based on good observation and the clinical experience of all those involved. Recognizing the symptoms in time gives the opportunity to provide good information and, if necessary, to treat the symptom. As that approaches, there is often a relatively sudden decline. The person becomes very tired and weak, eventually becoming completely bedridden. Because of this weakness, the person will take in less food and fluid. As a result, the person may lose weight rapidly, causing a typical facial expression with a pointy nose. Next, there may be symptoms resulting from reduced circulation. The pulse may be weak or absent due to reduced circulation. The skin becomes marbled, which can cause purple-blue skin discoloration known as livido mortis on the back, arms, or legs. There is reduced to no urine production. In the case of George, already there was no urine production. And eventually the person becomes less approachable due to reduced consciousness. Other symptoms occur, known as late symptoms, occur even closer to death. So these symptoms are really at the final phase. As the normal coughing and swallowing reflexes disappear, mucus may build up in the throat or windpipe, and there may be audible rasping breathing. Breathing also becomes increasingly irregular, with more and longer intervals between breaths, known as Cheyne-Stokes breathing. In addition, the brain begins to function less well, which can lead to increasing disorientation accompanied by confusion, hallucinations, and terminal agitation. In the next slides, we will describe these symptoms of the dying process in more detail and make suggestions on how to interact with or involve close ones. Now, George. So, George's children arrive at the hospital in Spain, one after the other. They are received by the medical staff and are informed about their father's condition. The physician explains that Josh's situation remains critical and that further treatment will depend on his recovery and the cause of the bleeding. The children discuss possible options with the doctors and, despite their concerns, support each other as best they can. Communication with the doctors proves to be challenging, as the doctors speak little English and George's children understand very little Spanish. This leads to a great deal of confusion and uncertainty for the family. They do their best to understand George's situation and the proposed treatments, using gestures, translation apps, and assistance from the nursing staff. When the children arrive in their father's room, they find a subconscious man with a grayish complexion, sunken eyes, and cold hands. The monitor shows a low heart rate. The son, who is a nurse, points out that George has been on dialysis for 24 hours, 7 days, so continuously dialysis, and that only medication is keeping his heart beating. The presence of his children clearly brings George comfort, although he is very weak. So, sorry. So reduced contact, reduced awareness, which was now the case in with George. So the period during which the patient is awake becomes shorter. The dying person seems to become more and more withdrawn and less responsive. As that approaches, it becomes increasingly difficult to speak to them. Although the patient is unlikely to understand everything that is said, the patient remains sensitive to sound until the final moments. It is important that close ones understand this, so discuss this with them. Ask that not too many people are present at the same time and to speak quietly. This will create a calmer, more serene atmosphere. Also point out that touch, such as holding hands, stroking, massaging arms and legs, is valuable, but also that it can vary from person to person and from moment to moment. If close ones want to help with care, they should be allowed to do so. Helping with care can be a way for close ones to show closeness, to say a final farewell. So please, now in the chat, this is a true or false. People in the dying phase still need food and fluids, and giving fluids is essential during the dying phase. So is this a yes or a no? True or false?
We have a no, false, 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 no, false. Unanimity here.
This
Not
is
true.
clear. So indeed, people who are dying no longer need food and fluids. Their bodies no longer convert food into energy. Extra fluid can be burdensome and can build up in important organs such as the lungs. For this reason, extra fluids and nutrition are not given through a drip or gavage. The patient will also not feel thirsty. The lips and mouth may feel dry, as the dying person breathes through the mouth, produces less saliva, and the oral mucosa dries out. If you see this symptom, report it and find out what a protocol exists and or what products are used in your care setting to clean and moisturize the mouth. Explain and advise close ones who want to be involved in oral care that food and fluids are no longer needed for people in the final phase of their life. The circulation slows down. And so how comes? Because the body maintains blood flow to vital organs, such as the heart and lungs, for as long as possible. Slow blood flow to the less important parts of the body, such as the hands, arms, feet, legs, and nose, can make them feel cold. It is important to explain this as well to the family and the close ones. The color of the face becomes more pale and purple-blue spots may appear on the legs, known as livido mortis. The characteristic facial changes at the end of life, including a pointy nose and chin, sunken temples, and a pale or grayish color, occur because the small blood vessels are no longer supplied with blood. So it's important to explain this symptom to the close ones and reassure them that it is natural and that the patient does not suffer from it. And so during the dying process, the brain functions less well. This can lead to changes in behavior. Dying people are often described as having a different gaze and are appearing restless and confused. They seem to be seeing and experiencing all sorts of things, but it's not clear what exactly. A common sign are small hand movements, as if they want to say something or point at or grab something. Observe the behavior of the patient and signal if you see signs of severe discomfort. The physician may decide to start sedatives in cases of terminal agitation. Advise close ones that they can be present in silence and that there is no point in trying to explain to the dying person that there is nothing there. Another true or false. The typical irregular breathing of a dying person is burdensome to that person.
Ready? Have a quick false in the chat. False. False. Unanimity again for now.
Oh, again, this is correct. So rash or irregular breathing, known as Cheyne-Stokes breathing, is another symptom of impending death. The pauses between breaths become longer and the last breaths sometimes resemble swallowing movement. This type of breathing may continue for some time, but it's not felt by the dying person as suffocating. The normal coughing and swallowing reflexes disappear, which can lead to a buildup of mucus in the pharynx or trachea. This can lead to a rattling sound when breathing, which is called the death rattle. Although this can be distressing for the close ones, it does not do any harm to the dying person. The period of irregular breathing and rattling is followed by increasingly long pauses, shallower breathing, and finally the last breath, often no more than a sigh after a very long silence. Explain this symptom to the close ones and reassure them that it is natural and that the patient does not suffer from it. If you recognize, because we have seen a lot of symptoms now, so if you recognize symptoms of the dying process, consult with colleagues, please. Interdisciplinary collaboration and alignment of care is important at this stage, and the goal of care has to be adjusted to terminal comfort. Ensure that everyone is observing in the same way and provides appropriate care. Inform the patient, close ones, and caregivers involved. In this conversation, mention that it is difficult to predict how long the dying phase will last. Provide space for the patient and their close ones to express their wishes, concerns, fears, and questions. Inform them about cessation of life-prolonging measures in consultation with the doctor and the importance of interventions aimed at the patient's comfort. Explore the values, wishes, needs, emotions, and concerns of the patient and his/her close ones. The patient may be dying at home, in a residential care facility, in a hospital, or in a palliative care unit or hospice. Whatever the setting, the patient and their close ones should be well surrounded and supported. Discuss with the care team whether specialist palliative care should be involved or not. If we continue with the story of George, so the children are in the room with George, his wife is present, and so he is on a constant dialysis, and then the child/nurse saw that his heart is heavily supported by medication. So George experienced a moment of lucidity. He recognizes his children, and they talk for a while about everyday things. George is aware that he is dying. The ICU nurse comes by to check how things are going. George, who speaks Spanish well, asks the nurse if he is dying. The nurse replies the situation is very serious. For this reason, the team wants to perform one last gastroscopy. Before the gastroscopy, George had a private moment with his wife, telling her that he loves her and is thankful for the life they had together. So they do the final gastroscopy. However, this procedure fails due to cardiac failure, and George is resuscitated. Afterwards, all medical equipment is turned off. Only morphine is continued and increased. George is no longer conscious. So now a question to reflect on. Should a child, so now George went to the terminal phase of life. So should the child, who is a nurse, take on the role of grieving child, of the nurse, or both roles? We
We
have
have
one vote
child,
for a child.
maybe best the child, child. Only child. Consensus again for the moment.
So we go for the role of a child.
What he thinks is best. It's not our place to decide.
It's another possibility. The story of George will continue during the webinar, so keep in mind what your answer is. In the dying phase, you care for the patient, the close ones, and the caregivers. So, medicines, just another question, true or false? Medicines such as morphine affect the duration of the dying process. True or false?
False, false, false.
So we will find out in a moment. So caring for the dying patient, so you tailor care primarily to the needs of the patient. As soon as you recognize palliative care indicators, you have had ACP conversations with the patient. Even during the dying phase, you continue to verify as much as possible what the dying person wants at the moment. When the dying person has lost consciousness or has become less accessible, you continue to consider any wishes the patient has expressed. There are two important things to strive for in the dying phase, namely to maintain quality of life and to make dying as comfortably as possible. Then you are providing terminal comfort. Care is organized in such a way that there are no more burdensome medical and nursing interventions. Blood pressure, pulse, temperature, saturation no longer need to be measured. Additional examinations are avoided and the need for fluid administration is discussed. Medication is often administered to make the dying process as dignified as possible. However, symptoms linked to the dying process are only treated if they are perceived to be uncomfortable for the patient. Medications such as morphine to relieve pain and breathlessness or midazolam to calm down and make sleepy are used to make the dying process as peaceful as possible with as little discomfort for the patient as possible. These medicines increase comfort and do not affect the duration of the dying process. So it was the answer of the previous question was false. Caring for close ones. It is emotional for close ones to say a final farewell to a loved one. But there are both difficult and beautiful moments in the dying process, moments of sadness, fear, helplessness, anger, but also of gratitude, love, sacrifice, humor, and hope. Close ones continuously need clear and honest information on medical, nursing, as well as experiential aspects of the dying process. When the bereaved need support, they should be able to turn to the committed healthcare professionals. Listening empathically to the fears and concerns of close ones, as well as explaining the dying process, can bring peace to the situation. Every dying process has its own pace. That can come quickly, but dying can also take a long time. In that case, for close ones, time seems to stand still, and they often experience time differently. Time becomes a double-edged concept. This final phase may feel very long, while at the same time there may seem to be too little time. Close ones, and even caregivers, may question the meaningfulness of this phase. The close ones may then ask, how much longer will it take? Why is it taking so long? Can't you do something to speed things up? As a healthcare professional, explain and inform that each dying process has its own pace, and it's important for the patient to respect that pace. Afterwards, close one may feel guilty for having had or expressed such thoughts. It is important to acknowledge and normalize these feelings, including those of guilt. Another true or false: keeping vigil may help with the grieving process. And so in the dying phase, there should be attention for the close ones, and close ones often have a need to be heard during the end of life phase of a loved one.
A big true. Yes. True. True. Yes. Consensus again, Dennis.
All right. So, and again, this is correct. So keeping vigil is about being present and reflecting on the past, sharing stories and memories. It is a way of consciously saying last farewells and letting go. During the dying process, some close ones want to be present almost constantly. It helps them to grieve if they can be present at the moment of death, if they can accompany the dying person until the last breath. It is important that close ones are given the opportunity to keep vigil. Some close ones, however, do not wish to be present, and this choice should be respected as well. Keeping vigil can be emotionally and physically demanding. As a healthcare provider, you must take care of the person who is keeping vigil. Consider offering a comfortable chair, a bed, food and drinks, and a listening ear. Emphasize that it is important for them to take adequate rest and offer support. Volunteers can provide support for close ones giving vigil, but they can also be important in the dying phase of a patient who has no one keeping vigil. These volunteers can help at home, in a hospice, in a residential care facility, or in a hospital. Please check specifically for your country if there are organizations where you can ask volunteers if a person is dying and has no family or close ones left. Moral distress experienced by healthcare providers is lower when they can provide good care. And all healthcare providers are trained to deal with that.
We have a false.
This is a more difficult one because the answers are not going that quickly. But now we more have a false, the first one true, the second one false.
I think
Let's
people are hesitating because it might not be the same answer to both questions this time.
Care for caregivers, including yourself. Confronting death is also stressful for healthcare professionals. It's important to provide good care, emotional support, communication, assistance, and post-death support. Being able to provide care according to the patient's wishes reduces moral distress for healthcare providers. Good advanced care planning and open communication with the patient and close ones is important. Secondly, on emotional support, it is important to be aware of your own and your colleagues' emotions. Acknowledge the emotional impact on the healthcare provider of caring for a dying person. Reactions such as grief, sadness, being emotional, frustration, relief are logical and normal. Healthcare providers may be confronted with the finality of life and their own end of life. Caring for the dying may conflict with healthcare providers' personal values and norms. It is important that the healthcare providers are aware of their own values and norms and are given the opportunity to do so when they experience conflicting feelings. Communication. Ensure that the healthcare providers involved are aware of the impending death and are always well informed. Explain to the patient and close ones that it is normal to share information with the other healthcare providers involved. Record end-of-life decisions and observations prominently in the patient's record. And finally, assisted and post-death support. Ensure that there is sufficient expertise in end-of-life and terminal care. Make sure to involve colleagues, palliative care specialists, and volunteers in a timely manner. Try to give the healthcare provider enough time after caring for the deceased, and not to resume day-to-day care immediately. It is important that healthcare providers can attend the funeral if this is the wish of the close ones. Afterwards, you can reflect with the team on the course of events surrounding the dying process. A debriefing session can help healthcare providers to learn from practice. During these sessions, you reflect together on what went well, what went less well, and what you can learn from the events and feelings involved. Feelings have a big impact on the way we care for people, so it is important not to ignore them. Being able to let go is important for everyone. And so we go to the final farewell. You can only say a final farewell when a person is in the dying process. True or false?
False.
And this is the last true or false. So
Everybody thinks it's
everyone
not
goes for
correct.
false. So when people think of a final farewell, they often think of paying their respects or going to the funeral. However, it is possible and even advisable to say the final farewell while the person who is dying is still alive. Therefore, replace saying final farewells in the cure care scene just before and in the terminal phase. Everyone says goodbye at their own pace, and it's often the process that continues until the person has passed away. Consciously saying farewell to a loved one can help you approach the end with greater peace of mind and come to terms with their death more easily. Saying farewell means different things to different people, but in general, saying final farewells means making sure that the things that need to be said are said and the things that need to be done are done. A tangible memory can be helpful and offer support in this process. For example, creating or showing a photo album about the life of the person who is dying, or taking a fingerprint of the person and placing it in a keychain. Saying final farewells does not always have to be through the spoken word. Not everyone feels comfortable talking to the person who is dying. It is important to normalize this and encourage the person to find a way of saying final farewell that suits them and the patient, through a look or a gesture, for instance. Final farewells need to agree with the person who is dying. Therefore, as a healthcare professional, it is important to be open to or facilitate a conversation between people who are dying and their close ones. For example, some people who are dying may want to have a last meal together with their close ones, or may want that anyone who still wants to can pay them a visit at a time when they are conscious. People who are dying may have already thought about their wishes regarding the end of life. These may be medical decisions, for example, palliative sedation, but also funeral arrangements or a ritual that is important to them. For example, the last sacrament for Catholic people. It is important that such matters are discussed, for instance, during advanced care planning. Although adults often want to protect children from death, children are not naturally afraid of death. They do mirror the behavior of adults around them. Being able to see a person who is dying or a deceased person with their own eyes can help children to understand what has happened and gives them the opportunity to say a final farewell at their own pace and in their own way. However, it is important to prepare the children well beforehand and to support them with it both during and after the final farewell. The death of a loved one can be profound and life-altering event. Everyone copes with it in their own way. Some may feel deep gratitude and laugh alongside their grief, while others may continue to wonder whether they did not enough for their loved one. Such thoughts can cause stress, which may lead to a period of chronic stress. This stress can cause a person to become either overly tense or conversely not tense enough to function properly. The window of tolerance, which is shown over here, describes the emotional range within which the window of tolerance describes the emotional range within which a person can cope effectively with stress. After the death of a loved one, people may experience strong emotions. If emotions become too overwhelming, they may feel agitated or panicked. If emotions become too distant, they may feel numb or disconnected. When they are in the window of tolerance, they feel emotionally stable and in control. Understanding the window of tolerance helps caregivers recognize and support different emotional reactions during the process of final farewells and the grieving process of close ones. In the table, physical responses that can occur as a result of chronic stress are summarized. What is the importance of final farewells? Some people may not want to say final farewells or may prevent others, such as children, from doing so because they want to protect the dying person out of concern and with the best intentions. They are in denial of the approaching death. As long as there has been no farewell, it isn't real. Is that might be a thought? They simply do not know how to say final farewells. However, saying final farewells and aftercare in the grieving process play a crucial role for bereaved families. If they do not receive adequate support around the process of final farewells, feelings of sadness, disappointment, and even guilt often emerge, which in some cases manifest themselves as persistent grief. As a healthcare provider, it is important to listen carefully to the reasons why someone may not want to say final farewells, while acknowledging and normalizing their fears and insecurities. Of course, no one can or should be forced to say final farewells, but it is valuable to open the conversation and explore the underlying reason. As a healthcare provider, you can also serve as a bridge between the dying person and their close ones by facilitating dialogue and explaining what saying final farewells can mean. For example, you might explain that for many people it is important not to leave anything unfinished, ensuring that everything that needed to be said or done has been expressed. It is also entirely normal for someone to feel unsure about how to say a final farewells. You can support this process by reassuring them that the dying person may still hear and feel their presence, or preparing them for what to expect, what they might see in the room, what sounds they might hear, for example, noises from medical equipment or natural symptoms of the dying process and what they mean. When that occurs, everyone will deal with the loss in different ways. Loud or quiet grief, relief, guilt, anger, and physical symptoms such as fainting. Make that a reality for the bereaved. Name the reality of the loss. Allow close ones to be involved in the final physical care if they wish so. Respect spiritual beliefs and cultural wishes. It is important for the healthcare provider to be aware that with that the close one has become a next of kin and the attention previously focused illness and disease has come to an end. The period between death and the final care of the deceased provides an opportunity for the bereaved to take a pause. Ask the next of kin if they have ever seen a person who has died. Explain to those that they were not present at the moment of death what the deceased looks like before going to see the deceased. Allow time to be with the deceased and provide space for sharing emotions and feelings. We go back to George. George does not regain consciousness and passes away after approximately 2 hours, surrounded by his children and his wife. One of his children holds one of his hands, while his wife holds the other one. In his very last moments, George whispers to his mother, who has passed away 8 years ago, telling her that he is there and is asking her to come and get him. After his passing, each child and his wife are giving an individual moment as well as a collective moment together with George. Now, the question is, what did the child nurse do? So previously in the answers, it was advised to take on the role of the child. And so the question was, is it the role of the child, the role of the nurse, or the role of both? And so the nurse child decided to take on the role of the nurse because they were in Spain. It was very difficult in communication because the medical staff only spoke Spanish. The nurse was also an end-of-life care specialist, and so he decided to take on the role of the nurse to support his family, and he thought that might be the wish of the father as well. And how was this for the nurse? This was very hard for the nurse. It was very difficult for the nurse. And the reason I know why it was so difficult is because I was the nurse child. So the story of George is the story of my own father. He passed away in Spain during holidays. So at that time, even though you are an end-of-life specialist, that was my decision to take on that role. So even though you have, and why I'm telling this story, even though you have all this theory and about support for the family, it's not always possible to take on the role you wish to take on. And so this was the story of George and the last farewell of other people and other loved ones.
Thank you very much, Dennis, for a very nice presentation, I think. I don't know if there are still questions. People are praising you for sharing your story. But this is still an opportunity, if you have questions for Dennis, to ask them in the chat. So we'll just give people a few minutes and we'll see if anything comes up. Let's see, every patient is unique and also special. Great presentation. Okay, if we have no questions, I think Patricia has a couple of closing remarks and also the announcement of our last webinar. I think, Patricia, you also covered that, right?
Thank you. And first of all, Dennis, thank you. That was a fantastic presentation. It was informative, but also incredibly sensitive and moving. So thank you for sharing that with us. I think we've all learned from it. I want to just present just the details, as you can see in the chat, of our next seminar, our webinar that is coming up. And that we're taking a break next week, as you may realize. Many of us are traveling to Helsinki for the EAPC Congress, and we hopefully will see some of you at that. So just so that you can see, the next webinar is on the 3rd of June, and the details are here if you would like to register. There you have the details for the website in the chat, and then you have the QR code here on the screen. What I will also say is that we have a certificate of attendance, and you can download that by also using this QR code. And there you will also see the evaluation form. I will put this into the chat as well, the details of the evaluation form. And we would really urge that you fill this out. And then for us, it means that it's a way of getting information about how the webinars are for you, and so that we can gear for the next group of webinars that will happen in September. We will have 4 more webinars starting in September on self-efficacy and for nurses and palliative care. All that leaves really is for me to say thank you. Thank you very much to Dennis for that incredible presentation. Thank you to Danny again for chairing. And most importantly, thank you all for joining us on this Friday afternoon, and to mind yourselves for the rest of the afternoon, and to wish you all a very nice weekend. Thank you very much.